start the recording so that we can post this later. But we are so thrilled that you can join us and give this lecture. So take it away. I'll be monitoring the questions. For anybody who has any questions, please put it in the chat or the question and answer box, and then we'll hopefully have some time after for Q&A.
Wonderful. Thank you so much for the introduction and for the invitation, Adam. I feel that this is it's a tough act to follow to try to lecture on pediatric neuroradiology right after ASPNR. But anyway, here we are, and I am very, very grateful to you for this invitation and to the folks that took time out of their afternoons to be here. Also, well, ASPNR may just have passed, but it's never too early to advertise the next one, which will be in San Diego. And me being here in Boston, the thoughts of warmer lands in San Diego already get me excited. So without any further delays, I'm going to talk about how MRI can help us understand normal fetal brain development. And this picture in the background of the tip of an iceberg, it seems really fitting for what we do in fetal imaging, because we're trying to gauge a lot about what's going on in someone's neurodevelopment just based on imaging that is in and of itself a challenge. So let's go through it and let's see where we can get together. So here, I'm trying to highlight a few of the processes that take place during normal human brain development. So very early in gestation, in the first 10 weeks, we have the cleavage of the hemispheres. The commissures are formed really early on, really truly by 12 weeks. You see them histologically. Neuronal migration is incredibly active, starting right at the cusp of the start of the second trimester, and it goes all the way to the early third trimester. And myelination kicks in around 26 weeks of gestational age. And cortical folding, it starts to develop in its rudimentary stages around the 20th week, but really sparks up exponentially after the 30th week of gestation. So I am now highlighting with this square the age at which we perform most of our fetal imaging. So most of this talk is going to be centered in the events that occur in this time period. And that is for the reason I mentioned before. This is the time period at which we perform most of our clinical fetal imaging. I think it is a very interesting question whether the recent changes in access to healthcare and pregnancy and abortion services, and whether that will shift our window and make us look earlier on to perform some counseling. But as things stand, this is really where the bulk of our fetal imaging occurs. So before we get into some details about the fetal brain, let's talk a little bit about technique, because I think some of us forget about the amount of effort that goes behind getting those images and how important that is. So this is the setup that we currently use at Boston Children's. So we use exclusively 3 Tesla magnets. We use a 1.5T basically if we fail and if it is a patient with poly or some other issue. But for the most part, even those patients, we will try on a 3T. We use the built-in spine coil from the MR scanner table that buys you about 18 channels. And we tend to use a 30-channel abdominal coil. The 30-channel abdominal coil has several advantages. One of them is it has many channels, and that allows you for good signal-to-noise ratio. The second advantage is that it is a large coil. So if you're uncertain about the position of the fetus within the gravid abdomen, it buys you naturally a fairly large coverage. On occasion, we use the 18-channel abdominal coil, but we really use this for either very early pregnancies or if the mom is unusually thin. And it is nice. It is a nice coil. And as you can see, the receiving elements are actually a little larger. So they actually penetrate really nicely into the tissues. The second thing, and I cannot overemphasize this is not just courtesy. It is actually instrumental to the quality of the fetal imaging to ensure that mom is comfortable for the duration of this kind. It is nice if you can have mom be on her back, because then you'll buy the full synergy of the anterior abdominal coil array with the spine coil. However, that very rarely works because the more advanced pregnancy is, mom may get tired being just flat on her back for the entire duration of the exam. More often than not, we place moms on their left side down, and we use the anterior abdominal coil like you can see here in the slide and we leverage the coil elements in this spine from the table. Pillows and all the cushions you can get to ensure that mom is safe and comfortable during this scan are well worth the investment. If she were to be on her back, you would place pillows under her legs to make sure that there's no sprain or strain on her back, and you would have enough padding on her head. Same thing would hold true if she's on her side. You'll probably help her with a pillow between her legs, some pillows for the head, and also some covering to ensure she isn't directly touching the coil or the bore of the magnet. For obvious reasons, pregnant patients are larger than many of the patients we have in our children's hospital. So we tend to use a 7-centimeter bore rather than a 60-centimeter bore magnet. And the issue of spatial resolution is truly fundamental for fetal imaging. The patient is the smallest patient you will ever image. So I think it is incumbent upon us to touch briefly upon this factor. So the first thing is that even though we call all the images that we do in fetal imaging, or the large majority 2D images, the reality is that all images in and of themselves are 3D images. So we look at them in 2D. But I think it's really important to think about them in 3D because the slice thickness is always incorporated into your image acquisition. Sorry, the slide jumps. So in plane, it is your field of view and your matrix that will determine your in-plane resolution. Your through-plane resolution was going to come from your slice thickness. And in reality, as I said, you're always imaging in 3D. So you're always imaging a voxel. So just remember that your in-plane resolution comes from the matrix and the field of view, and your through-plane resolution comes from your slice thickness. The smaller the voxel, the better your spatial resolution, but the lower your signal. So you have to strike a true balance. And that's one of the things that are really helpful with imaging at 3D. I wanted to further illustrate this with an actual fetus and showing serial changes in those images so that you appreciate what you're buying with each one of these steps. So the first thing I wanted to show you is even though you're imaging a 3D, if you have a large field of view and a small matrix, your images are going to be blurry. If you adjust the field of view, just decreasing the field of view, that will buy you some spatial resolution. But notice that it is not until you adjust the matrix too that you're really going to get a crisp, nice diagnostic image. So you have to realize that just putting someone in a 3D magnet won't cut it. You have to tweak the parameters to your advantage. Last, I'm just kind of showing off here that at 3D, we actually can lower down our parameters really nicely and get pretty stunning spatial resolution. The last thing to point out here is through all of these changes, the slice thickness has remained constant. So just realize that slice thickness truly is not the only factor that governs your image quality or your spatial resolution. Your field of view and matrix are crucial for the in-plane resolution. So now let's get started to feed on actual fetal brain development subjects. So the first one that I mentioned, and it's the first one that happens chronologically, so I'll address it early, is hemispheric cleavage. So hemispheric cleavage really happens in the first 10 weeks of pregnancy. So basically at any time that one of these patients come to our departments of radiology, hemispheric cleavage should be well done and unequivocal. You should really be able to see both hemispheres, which are the result of the two cerebral vesicles. You should see the two ventricles. And if you're doing imaging with enough spatial resolution, you actually can catch the corpus callosum nicely, either on the sagittal or in the coronal plane. So you typically really see it very, very nicely, and it shouldn't be equivocal. Yet we see a fair bit of abnormalities of hemispheric cleavage as part of our syndromes, and I've outlined a couple of them. The first one is a lobar holoprosencephaly. These are relatively common in syndromes and some trisomies. The sine qua non that we should look for is this sort of pancake or banana-shaped anlage of parenchyma and a single ventricle. So I think the single ventricle is actually very useful because sometimes the orientation of the tissue is a little confusing. But if you have one ventricle, you're really dealing with a lobar holoprosencephaly. If you have a semblance of hemispheric cleavage, and by a semblance of cleavage, I mean you have at least some rudimentary temporal horns, you're probably dealing with semi-lobar holoprosencephaly. Now, if you have even further attainment of hemispheric cleavage, you're probably in the territory of lobar holoprosencephaly. And I must say some of these are really, really difficult to pick up. They can be very, very subtle. And that's when really looking and scrutinizing your images very carefully for the ventral forebrain, because in the most subtle cases, that's the part that's missing. Cleavage of the ventral forebrain is what's going to help you with the diagnosis. And notice that the construct of the ventricular system is much closer to what we would see in a normal brain. I should emphasize that even though there is a continuum in the anatomy of these diseases, from a lobar to semi-lobar to lobar holoprosencephaly, in reality, all holoprosencephalies are pretty severe diseases, and all of them, even lobar holoprosencephaly, tend to be associated with substantial developmental delay and epilepsy. So really, none of them is a mild disease. The last one I wanted to point out, and this is kind of a cousin, it's sometimes lumped together, but I tend to be a splitter rather than a lumper. So the mid-interhemispheric variant of holoprosencephaly has something to holoprosencephaly because the hemispheres are fused. But if you remember what I said, holoprosencephalies are a defect in the cleavage of the ventral forebrain. The ventral forebrain has to be uncleaved. And this is not the ventral, it's the dorsal. So this is a different type of holoprosencephaly, has different association. It is, there's some continuity in the dorsal part of the hemispheres. The corpus callosum has a very peculiar dysgenesis right in the middle of the body, corresponding to this area of dysgenesis. And the salient fissures are also peculiarly rotated into the coronal plane. So let's switch to a completely different substrate, and it's the extra-axial CSF spaces. And I think it's frequently forgotten, but of tremendous importance. So I'm showing you some data that's actually plotted from some of our studies that we've done on normal fetal brain development. So in red, you have just the extra-axial CSF space, and in blue, you have the entire intracranial volume. So what I wanted to show you is twofold. First, the extra-axial CSF space volume increases through pregnancy. So it never starts to decrease. The actual volume of CSF always increases, but the volume of the entire head actually increases more, which means that brain tissue is actually growing faster. So you will see a relative decrease in the percentage of the brain that's occupied by the extra-axial CSF space. So that's something good to remember. That is the normal trend. And I think there are a couple of other things that are important to check for. The first one is symmetry. In general, this is nicely distributed in a symmetric fashion across the convexities of both cerebral hemispheres. And just keep in mind that there can be problems from having too much or too little of it. So this slide is showing you just the progression of the changes, because what I'd like for you to see is to also get somewhat acquainted with how these images change through pregnancy. So I'm showing you on the left side of the screen a 17-week-old, and on the right side of the screen a 35-week-old fetus. And you can appreciate that at every stage there is CSF surrounding the convexities, and you should always see the sulci. But you can see that before 30 weeks of gestation, really, you can appreciate generous CSF surrounding the entire cerebral hemispheres, whereas after 30, the spurt and growth of the brain is faster. So you can see that it will actually take some of that space back. Now, showing you a little bit of pathology, I think this is really important. So as I said, you can have problems because you have too much or because you have too little CSF. On the left side of the screen, you have a cobblestone lysencephaly, so or a dystroglycanopathy. So as you know, this diseases are fascinating because the problem is that the migration of neurons doesn't stop where it should. So they arise normally. The germinal centers, they start to go outward to find their cortical targets. But when they get to the cortex, they don't stop. They go out and continue. So one of the things you frequently see is a paucity of extra-axial CSF spaces. So having shown you a 22-week-old normal, you can clearly look at this and say, okay, there is a lack of CSF spaces here. And obviously, there are a ton of other abnormalities here. The brainstem is kinked, the cerebellum and vermis are abnormal. But just appreciate that one of the hallmarks of this malformation is a paucity of the extra-axial CSF spaces. The second contestant here is one that you probably all know much better, just because it's more common and has received more attention in the literature, and that's a open spinal dysraphism, a myelomeningocele with a large ventricles and also paucity of the CSF spaces. And that's very important in the sense that there's a very mechanistic explanation for that. And I think our understanding of this disease has changed through with the onset of fetal surgery. One of the main and crucial problems in fetal spinal dysraphisms that are open is that the leakage of CSF results in this. The CSF is coming out through a defect in the spine, so it kind of doesn't go through the convexities And it's one of the things that is directly addressed by fetal surgery. If you guys are familiar with fetal surgery, then you'll know that it is a very elegant and impressive technique, but it is not as if the surgeon goes in and dissects nerve by nerve and tries to reconnect things where they are. They basically carve a little hole around the neural plateau as much as they can, and they shove it back in. And after they shove it back in, they try to cover it with either native skin, or now they're using some other patches. And that is an attempt to address that leakage of CSF as a fundamental problem in the pathophysiology of Chiari-2 deformities. The third thing I wanted to show you is an arachnoid cyst. So garden variety arachnoid cyst, we see them not infrequently. And you can see there is an asymmetry in the left middle cranial fossa. And one thing I would say, and I think this is an important take-home point, is many of us have seen arachnoid cysts, by the thousands. And in adult, they don't mean much. And in older children, they also don't mean much. However, in fetal life and in early neonatal life, I have seen them grow. So I won't say that all of them grow, but a percentage of them grows to the point where they get into trouble and they sometimes need to be fenestrated. So I have seen a handful of those, and I actually think it is perfectly reasonable to follow a fetus with the only abnormality known being an arachnoid cyst, because they can grow and they occasionally need a bit of help after they're born. So proceeding with normal sulcation, which is, I think, one of the more challenging topics, I took some of our normal fetuses, reconstructed them in 3D, and built this for you guys to appreciate the spatial arrangement and the evolution of the folding of the brain. So you can see that in that sweet spot where we get most of our fetal exams, which is, give or take before 24 weeks, so 20 to 24, the brain is still fairly smooth. So you have a very clearly and nicely generated solvent fissure. You have the interhemispheric fissure. We've beaten that one to death. And we have the parieto-occipital that's starting to develop. But really, the overwhelming majority of the hemisphere is still smooth. Now, jumping to 27th, you start to see the development of some of the large primary sulci here. So you have the superior temporal and the central, but it really isn't until 30 that this really kicks off and that secondary sulcation really starts. And you can see that at 37, it basically looks pretty much ready to be a newborn. So I wanted to show you that now in 2 dimensions and emphasize a few things. The first take-home point of this slide is beat down a little bit of the skepticism. I am a believer in 3T. I think it is a little more challenging than imaging at 1.5T, but I want to convince you that if you do things right, you can actually get really good images throughout the entirety of gestation on 3T magnets. So getting back to our sequence of sulcation, so realize that if you image in the early or in the middle second trimester, so before 17, the brain is still fairly smooth. So you will have your interhemispheric fissure, but realize that you actually have to struggle to find the indentation for the Sylvian fissure very early for that fissure to, even for the Sylvian fissure to be seen before 18 weeks. At 22, which is in the middle of that sweet spot where we get a bunch of fetuses, you actually see the Sylvian fissure very, very nicely. But really, that may be it. Even the central sulcus is not developed at 22 weeks of gestation. So you still have a fairly smooth brain. The central sulcus develops, give or take, 25, 26 weeks. So you can start seeing just this little notch. This little notch here and there is the central sulcus as it starts to develop. And it is really important to also appreciate that a certain degree of asymmetry in the emergence of this sulci is perfectly normal, and one shouldn't be too alarming. Many of them actually progress slightly faster on the right side. So some asymmetries are known to occur and favor the early appearance of some of these sulci on the right side. But other than gaining that sulcus, that central sulcus around 25, really not many other sulci have developed. The next large one to develop is the superior temporal sulcus, which appears around 27. And you can see that in this 28 weeker, it starts to develop, right? Very easy to see and nice to see in the coronal plane. And obviously, the sulcation continues to advance in the frontal lobes. By 30 weeks of gestation, and I'm not going to go through each one of these sulci, don't panic. By 30 weeks of gestation, what I wanted to show you is now we're starting to really get a convoluted surface, but there is a posterior to anterior gradient. So you can see how this posterior temporals and occipital lobes are fairly sulcated, whereas the frontal ones remain somewhat smooth. They'll catch up, right? So you can see here later in gestation, they're starting to develop their sulcite. But at 30 to 33 weeks, you can predictably expect a certain asymmetry with more advanced sulcation of the posterior aspect of the fetal brain. Now showing you a couple of abnormalities of sulcation. So if you look at this top row, we have a fetus with known CMV. There are a couple of things that are wrong with this fetus, but you can see that the salient fissures are very shallow, more than they should. And we can go back and forth. Probably this is facilitated by tissue loss. If you look at the normal H-match control in the lower part of the slide, you can clearly see that this brain is lacking meat. So perhaps that's why the sulci are shallow. At 28 weeks, this one is tremendously abnormal. This is a patient with Dysgenesis. You really have no sulcation. This is completely abnormal. A patient with polymicrogyria bilaterally, you can obviously see that the sulcal pattern is abnormal. I would also add that a useful hint to finding polymicrogyria, particularly when it's localized, is asymmetries and areas of localized prominence of the CSF. So as we said, it's okay to have extra-axial CSF, but it tends to be fairly symmetric in the way it's distributed around the convexities. And then if you look just underneath it, you see that this cortical mantle has increased frequency of the gyri. And one of the conditions that I find very fascinating, sulcation can also be abnormal if there's too much of it. So this is an FGFR3 mutation. This is a patient with thanatophoric dysplasia. And in general, I would say our body colleagues are, they're all over it because the long bones are very short and all the features are there. But if you look at this, this is a very peculiar pattern of oversulcation of the temporal lobes. I have seen basically nothing that looks like it. So this is, in my mind, fairly characteristic of a thanatophoric dysplasia due to autosomal dominant FGFR3 mutations. And this was a companion with an H-match control that shows you that at that age, the temporal lobe should really be very, very smooth. Talking about the telencephalic wall and the layers of the fetal brain, it's one of the things that I've devoted some time to doing work in. And the reason is, in common parlance, they're referred as transient zones of the telencephalon or of the hemispheres. And for that reason, they're kind of unknown postnatally. Many of us, and I would say the field of neuroradiology certainly evolved with a bulk of adult patients and then kind of went backwards. But even when we see newborns, these layers have largely resolved. However, as our fetal imaging has gotten better and better, we are able to see the lamination of the brain. And that is very, very important. And we're using it more and more to diagnose diseases early, particularly localized injuries or malformations at earlier stages. So I've colored them so that we can sort of have an informed conversation about them, going from inward out. So the first thing is we all use the term germinal matrix, and I think that's perfectly fine. But in reality, there are at least two large, well-established proliferative zones in the depth of each hemisphere. And they give rise to different neuronal populations, and those neurons take different migration routes to get to the cortex. So I would say if you were to talk to a neuroscientist or a neuroanatomist, they would really kind of lump this into completely different categories. So in green is the ventricular and subventricular zone, and that's the one most people think about in the sense that this is the one that has a prototypical radial migration of progenitors from this zone all the way out through the cortex. In yellow, you have the ganglionic eminence, and the ganglionic eminence gives rise to neurons from the deep gray nuclei, and also a set of neurons that are inhibitory that follow a tangential pattern of migration. So they don't migrate radially out, they follow their own highway. So these two are very dark on T2 weighted images, as you can see, and it's because they're jam-packed with neurons. The next layer from inside out is the pink, and the pink is the intermediate zone. The intermediate zone is a very fibrous, rich layer that contains a lot of radial glial fibers that are going to help those neurons migrate outwards from this germinal center all the way to where they want to go in the cortex. They also contain some early developing axons. So some axons that have already established connections are going to traverse through this space. The third one is the subplate. And the subplate is colored here in blue. And it is a very T2 hyperintense layer because it actually has very few neurons. It's mostly extracellular matrix, growth factors. The neurons stop there for a second, take a break, it's a pit stop, and then they go to the cortex. Now, for neuroscience, the subplate is getting an incredible amount of attention. I am told by folks that know a ton more about neuroscience than I do that when you compare the brain of a human fetus to that of a non-human primate, that apparently humans have this humongous subplate. So, to purists and neuroscientists, this is one of the things that makes us stand out as human. The second reason to pay increased attention to the subplate is that it is quite vulnerable. And we've known that from studies in congenital heart disease and preemies, that the subplate neurons are actually very frail and easy to damage. And then the last layer is the cortical plate. And the cortical plate is this T2 dark layer also because some neurons have already gotten there. So the neurons that are there, much like the neurons in the proliferative compartments, make them be very T2 hypointense. I wanted to show you the evolution of these layers because they're not apparent at every single time point. You see them very clearly in the early second trimester. Your spatial resolution won't allow us to discriminate all of them, but you clearly see a subplate, you clearly see a proliferative zone and a cortical plate at about 17 weeks. From, I would say, 20 to 22, you actually can see the proliferative compartments, the intermediate zone and the subplate very nicely. At around 28 weeks, they start to fade out because those neurons start to make it all the way out. So it's sort of, you've started to ramp down your production of neurons here. The ones that have made it out have started their migration and they're starting to get to where they belong. So I would say the borders between the subplate and the intermediate zone are starting to fade. And by histology, a stage called the resolution of the subplate is typically accepted to occur between 30 and 31 weeks. So, by MRI, we're really losing the distinction and that nice zonal anatomy at the end of the second trimester. All right, I also wanted to show you T1 weighted sequences. I think given the amount of water in the fetal brain, it's so intuitive and convenient to use a T2 weighted contrast. But if you were to use a T1 weighted contrast, you can still appreciate some of those differences. So you can see that the areas that have high concentration of neurons, like the cortical plate or the proliferative compartments, have a shorter T1 and appear T1 intermediate or hyperintense, whereas the subplate, that as we said, is really watery and full of growth factors with only a handful of cells, that looks very T1 hypointense. This is another normal structure that I wanted to point out because I think what happens is sometimes you get a stunning fetal MRI where you actually get tremendous quality and you're like, oh no, what are these? And these little geometric triangles of T2 hyperintense signal are called the crossroads. The two most common ones and largest ones, so they're the ones that we on occasion catch up distinctly, are the frontal and the parietal crossroads. And these are normal. These are areas where axons that are at this stage unmyelinated are just crossing, as the name says, and it's a completely normal structure. So I think it's good to appreciate them so that if you were to see it on a fetal MRI, you don't get startled by having performed an awesome and beautiful fetal MRI. There's also pathology with lamination. I mean, you can see plenty of malformations. I am bringing two that are quintessential in and of themselves. The first one is a band heterotopia, and you can see two things here. You can see a band of neurons that didn't quite make it all the way to the cortex. I'm not going to discuss too much about the pathophysiology, but as you know, this is an X-linked disease. So this is a band heterotopia because one of the X chromosome carries the genes, and then when you inactivate one of them, some neurons don't quite make it out. I mean, I will grant to anybody watching this that in addition to the band of neurons that's arrested, the sulcation isn't entirely normal, and I think that's obviously completely correct. The second one that I'll show you is tuberous sclerosis. I think you can very clearly pick up on the fact that there are these blotchy areas of T2 hypointense signal all throughout the brain, and these represent tubers. You can see a few subependymal nodules too. If you sharpen your eyes, just realize that at this stage, because of the unmyelinated brain, the tubers are actually T2 hypointense. They are not as watery as the subplate or unmyelinated white matter. They contain more tissue, right? So basically these hamartomas or focal cortical dysplasias, or however you choose to call them, they have more tissue, so they have less water, and they show up as T2 hypointense and a disruption in the pattern of cerebral lamination. I wanted to show you, we are starting to see also some injuries and some malformations that present with an abnormality that predominantly affects the germinal centers. We saw one of these actually at the ASP now in a different mitochondrial disorder where the ganglionic eminences were large. So in this case, they were large and cavitated. They have undergone cystic degeneration. And this is a patient with pyruvate dehydrogenase deficiency. And this is the follow-up of that same neonate. There are a couple of features of pyruvate dehydrogenase deficiency. I'm not going to sort of dwell too much on that, but you can see, the ganglionic eminence is gone. You can still have some areas of gliosis and cystic change, but if you just looked at this as a newborn, you wouldn't say, oh, of course, this is the result of an injury to the ganglionic eminence. So as we started to look earlier and earlier, we were starting to comprehend a bit more about how some of these diseases settle and result into the phenotypes that we see later on. DTI is also something we are doing more and more. We do it both on clinical and for research. The main thing I want to show you is if you're doing ADC imaging, remember that those areas that are very T2 hypointense, like the ganglionic eminences and the ventricular zone and the cortex, are actually expected to show an element of decreased diffusivity. So they appear darker on the ADC and a little bit brighter on the trace. They're also highly cellular, so they actually show up with relatively high fractional anisotropy. So we're doing that quite frequently these days. I wanted to show you that it actually does help to pick up injuries. The fetus up top was a case of, these are actually two cases. The first one is a fetal demise. So, I mean, by the time you look at this, all the features of the fetal demise were there, but you can see that there's decreased diffusivity throughout the entire brain. And obviously the haze just confirms that by showing complete effacement of the sulci, the ventricles, and the extra-axial CSF spaces. The case on the bottom is a case of a veno-gallon malformation, and you can see that we can pick up acute venous ischemia. So I would say that would have been very hard to do on the haste, whereas on the ADC, we can actually see a blotch of decreased diffusivity. And this has proven very useful, and we worked better in this with Darren Orbach, our neurointerventionalist, because what we've seen, we published our experience, is that the high volume of shunting and venous hypertension that results from veno-gallon malformations actually can reach a threshold. And this is known from postnatal cases. If they start developing the melting brain syndrome, that's a really bad sign. The problem is that once you develop an area of true injury, not like a little bit of large ventricles, but if you start developing parenchymal injuries in a fetus, it is the same, which means you have reached the ability of that brain to auto-regulate. So it is kind of the beginning of the end. So at that point, it starts a cascade of ischemic factors. And what we documented is if we see acute areas of injuries with restricted diffusion, every single one of those fetuses, the injuries progressed, and either on a repeat fetal MR or a neonatal MRI, the brain has basically washed away. So we are using it to screen for acute injuries in these fetuses with the idea that it really has a very powerful prognostic indicator in terms of the neurological prognosis of that patient. So T2 star weighted sequences, I'm sure we use them all the time. We use them to look for hemorrhages. They are fantastic. One thing I wanted to say is appreciate that those two structures that I've kept talking about, well, they have more neurons, so they need more blood. So you frequently see the cortex be T2 hypointense on T2 star weighted sequences. And that's because there's also a venous plexus in the cortex that is very prominent early in development, and then it will start to regress. Much the same applies to the ganglionic eminences and the germinal matrix. And we all have an intuition to that, right? We've all imaged neonate and preterm babies that bleed into the germinal matrix. So we know they have a high concentration of capillary blood there. So I'm just pointing that out to you. Don't get alarmed if you do high resolution T2 star weighted sequences and you see that there's prominence of the ganglionic eminences because that's expected. You should really look for asymmetries or something else to cue you into that. These are a couple of cases where your sequences can help figure out pathology. So for example, we have a cerebellar hemorrhage here. I would also say the cerebellum has its own germinal matrix. And unlike the brain, the cerebellar germinal matrix or germinal layers are outside, are in the surface of the cerebellum. So this is probably a germinal matrix hemorrhage from the cerebellar germinal matrix. I would argue that the T2 haste here is doing all the job, but if you were to look for it in the T2 star, you'll see kind of blooming of those blood products. Similar thing can be seen. I think this is a nicer case. This is a germinal matrix hemorrhage. You could question whether there's something there, but when you do the T2 star weighted sequences, the asymmetry truly cues you into the hemorrhagic injury. The last one is the venogallant malformation. And as I was mentioning, the venous hypertension results in venous congestion. So you frequently can get to see prominence of medullary veins and other venous structures in fetuses with venogallant malformation because of that fast shunting and venous hypertension. Going now to the ventricles. So I wanted to show you this graph. This is also from our normal developmental fetuses and analysis that we did. So the first thing I would tell you is that even though we use a very rigid cutoff of 10 millimeters to determine normality when doing 2D measurements, the volume of the ventricles never stops growing. It continues to grow as a 3D structure. So that's just something good to keep in mind. And another thing that we see these, and actually sonography knows this, has known this for a while, but it was nice to be able to reproduce this. It's always the female fellows that get this question right. I ask them, who do you think has more water inside of their head, men or women? And they all like shake their head and say men. And they're right. So male fetuses have larger ventricles. So all of the women that are watching these are probably correct. And that men, even at early stages, have a little bit more water inside their heads. So their ventricles, when you measure them by volume, are a little bigger. I'm not advocating using this in clinical practice, but we were able to replicate this kind of long-standing known fact. For practical purposes, we still measure that, but also realize that even though the cutoff is 10 millimeters for a fetus early on at 15 weeks, just glance at it and realize how large these ventricles are relative to the parenchyma, right? So what we've mentioned is in the later parts of gestation, everything will continue to grow. The ventricles will grow. The extra-axial CSF will grow. But truly, there is a spike in that tissue, in the actual meat of the brain, that's going to drive brain development in those later stages. So ventriculomegaly, there would be a complete talk on what we can say about that. We stratify them into mild, moderate, and severe based on those two-dimensional measurements, as the slide shows. This has prognostic significance. Your chances of being normal developmentally if you have higher grades of ventriculomegaly decreases. I think it's also important to describe when we see them, whether it's symmetric or asymmetric, so that we can look for injuries or other potential problems. One thing that I would point out that I think is fairly important is that in fetuses that have severe ventriculomegaly and there are abnormalities in CSF dynamics, it's quite frequent to have this phenomenon occur. The septum pellucidum disappears, it gets resorbed. I don't know what happens to it. I think it dies because it's too thin, and if the pressure is elevated, it just gets resorbed. But the reason I'm pointing it out is because I see these very, very frequently, and it will result in this picture. No septum pellucidum, the fornix is drooping down, and then people go into the realm of septoptic dysplasia. But in reality, I mean, if you have no evidence, against it, septoptic dysplasia is a perfectly reasonable thought, but just realize that because you don't see the septum pellucidum does not necessarily mean that it was not there. It can be the result of a destructive injury arising from abnormal CSF dynamics. I wanted to show you now cases of asymmetry of the ventricles. There's no hard rule. Over here, even if both ventricles are normal, if the difference between the ventricles is more than 4 millimeters, we get a little nervous and we probably get a postnatal MRI. So this 32-week fetus has a fairly significant asymmetry. I think this one was 10 or 11 millimeters, and this one was 5. And it was very funny because what we found when we imaged the postnatal is that the smaller one, there was this tiny migrational anomaly here that you can see along the ependymal margin. On the other hand, this fetus, which had unilateral right-sided ventriculomegaly, we imaged, and there were some heterotopias on the right side. So I don't have a fast rule. I recommend to do what we do because it's helped me in a couple of times. Even if both ventricles are normal, if the asymmetry is more than 4 or 5 millimeters, I think it's worth taking a look, but you'll have to work with your clinicians on that one. I also wanted to say the shape matters. It isn't just the size, the shape actually matters. So this ventricle, as you can see, there are frontal horns, and no one was going to pass this brain as normal. But the fact that the shape, that the frontal horns are not dilated, is actually pretty alarming here. And that's what we found when we imaged postnatally. There's this really large right frontal malformation. The fetus below is a fetus with MPPH. And I would argue, no one's once again going to call this fetus normal. But if you look at this axial image, you'd be like, oh God, I'm actually not entirely sure what's the anterior and what's the posterior aspect of the head. And that's because the shape of the ventricles is completely normal. So even though these ventricles barely measure like 11 millimeters when you measure them at the atria, you can clearly tell that this ventricular system and the entire brain is not developing normally. A few words on the corpus callosum. So I think you truly see it consistently by 18 weeks. But what I would say, if you happen to image beforehand, just realize that it is a little short. So in my mind, if you image at 17 to 18 weeks, it's kind of about the size of the midbrain if you draw an imaginary line, right? So don't call this for short, and I think it's very normal to have this length of a corpus callosum in the 17 to 18 weeks. Afterwards, it starts to become longer, and it has this spelt appearance that we're all used to. So this is a normal appearance of the corpus callosum. I like seeing it in the sagittal, but you can choose what you like. I think it's a good practice to get used to looking at it in the axial too. And as I said, just realize that before 18 weeks, 17, 18, it's going to look short, and that's not a problem. It is just hasn't had enough time to grow yet. By 26 weeks, obviously, it's completely developed, and same thing in the later third trimester. Callosal dysgenesis is one of the most common indications, and you have agenesis of the corpus callosum, which I personally reserve the term agenesis to when it's completely gone. If the term partial agenesis, which I have here, I don't really like because it's like you are half dead or you're half alive. So I tend to say hypogenesis, but I think that it would just be a minor distinction. But I tend to, I've moved away from this because I think it sounds funny. And obviously they can be isolated, but they can also be syndromic. This is a case of Aicardi syndrome. So you see intrahemispheric cysts, callosal dysgenesis, and a malformation of cortical development. Vermis, I think, is the last structure that I'm going to touch on. This is cheating. This is an ex vivo fetal MRI, but it's good for the review of the anatomy. So, the first, above the primary fissure, you have the lingula, the centralis, and the culmen. Then you have the DFT. And I don't think we can actually differentiate this. I just tend to call this the DFT. And it has the declif, the folium, and the tuber. Then you have the prepyramidal fissure, and that one's easy because it's called prepyramidal for a reason. So you have the pyramid here. Then you have the secondary fissure, and then you have the uvula and nodulus. I feel the same way about the vermis as I feel about the ventricles. They can inspire whole talks in and of themselves. I think if you do good imaging, you can actually see the vermis fairly well early on. Now, there are these fetuses which admittedly are lagging a little bit behind, and you image them at 17 or 18, and they have a small vermis, and then you image them later on, and it's fine. In my experience, all of the ones that catch up are in the mild space. Like if you have a small vermis that's superiorly rotated, I never saw that come down. But anyway, I just wanted to show you, if you image early on, you may see the vermis, but just be nice to the fetus. It's not going to look as big as this one. But I think this one covers the fourth ventricle. It's perfectly nice. This is about as much as you could ask for an early fetus. For a 22-weeker, you can actually have the nice arboreal architecture of the vermis. So this is one of those at 19 weeks. It kind of wasn't entirely covering the fourth ventricle. At 22 weeks, it was perfectly fine. I wanted to show you the spectrum that we see. I tend to be very descriptive about this. There's people that have devoted many more hours and to characterizing this and diving deep into this. I am a very simple-minded guy, so I love calling what's normal. When I can't, then I just describe it. So this one is mildly inferior vermin hypoplasia, but I don't see that much rotation. This one has superiorly rotated, and this one has superiorly rotated, and there is enlargement of the CSF spaces in the posterior fossa. The point I was trying to make is a mild one. I have seen it sort of become normal if you image early on. So if you image an 18 or a 19-weeker, I can definitely see someone that has just slight vermian sort of underdevelopment grow up. But if you have a vermis that looks like this and that has a little tail pointing posteriorly, I have never seen one of those come down, lose the tail, and become normal. So I think even at some point it's fair to re-image, but I think your gut feeling tells you like this one's not going to end up looking normal. I wanted to show you that there are also more malformations and abnormalities than just inferior vermian hypoplasia. we see occasionally a couple of cases a year of rhombencephalosynapses, so I wanted to show it. First clue, the cerebellum is tiny. So if you do biometry by MR or by ultrasound, it's really small. Second, it looks like a ball. Like there is just a completely convex architecture to the cerebellum. So I can't say that I can see the stripes go through and through, but what I'll tell you is this rounded appearance, very characteristic of rhombencephalosynapses. And on occasion, we catch a molar tooth deformity or so. Last thing that I wanted to say is this will be also subject for a different talk, but I think it's very interesting. We are seeing an increase in the number of early second trimester MRIs that we see. They're not sent to us because of neuro problems. They're sent to us because an abdominal wall defect or something else, but you know the brain's there. And I think there may be a shift in the population we see as rules and various states dictate what can be done in terms of access to abortion, and people are going to travel or not travel. So I think this is fairly interesting, or at least it is to me. Also on the neuroscience part, I wanted to show you an example because it's very different. So I think it's very important to not be alarmed to the moment if you can. I think my take on this is they have a very low negative predictive value, meaning it's very hard to exclude that any malformation will develop here. A quintessential principle of fetal imaging is you cannot ensure that a process will be completed successfully until it's actually completed. So I'm not going to stick my neck out and say there will be no migrational anomalies in these fetus because migration hasn't occurred in its entirety. But I would say when you find an abnormality, it actually has a very high positive predictive value. So if you find a hemorrhage or a holoprosencephaly or something large, you actually can make that call because those events have happened in embryology. So I would say just realize they have very, very large ventricles. They still measure within range of normal, but obviously more than 50% of the volume of this parenchyma is CSF. Second thing is realize that the brainstem is also somewhat kinked. So please don't get too alarmed or raise concern for a cobblestone malformation if you're imaging at 12 or 13 weeks. This kinking, very, very typical. Also, see, this is the peculiar tectile plate. It's so funny. It's so prominent relative to everything else, and it stands out a lot, and it's also normal. The corpus callosum, it's there histologically. We know it's there by 12 weeks, but we don't see it. And I've tried hard, and I'm working on this right now. I very rarely see it before 15. It is a spatial resolution issue. But this 15-weeker, I'm like, okay, I think I can catch some of it there. Oops. But I would say hard to see on the other planes, hard to corroborate in the coronal, hard to corroborate in the axial. So don't get too alarmed. I think by 17 weeks, you should definitely see a corpus callosum. In most 16-weekers, you should. In most 50-weekers, I didn't. But you know, there's tons of fetal imagers here that are far more experienced and have sharper eyes. So with that in mind, I like to wrap this session up by telling you that I find fetal imaging to be absolutely fascinating because it's the most dynamic period of brain development for a human being. I love MRI. I'm an MRI person. And I think MRI demonstrates the growth and development in exquisite detail. And if we combine information that we get from T2 weighted sequences, from the Diffusion, T2 star, and now people are starting to do fMRI and other really, really cool things. So I really think this is a truly hot area for research and fascinating one. We are going to get, and we have already done a ton of work in the space of quantitative and advanced imaging over here. I think that's going to be fundamental for understanding some of these early processes and to be able to do quantitative phenotyping. As I mentioned, some of the metrics that we do have been very well validated, but are a little short, like using a non-varying cutoff of 10 millimeters for the ventricle, when in reality the ventricle is a 3D structure. So I think a lot is coming down the pipeline. And then for all those of us that do clinical imaging and that like quite a bit too, I think being aware of normal developmental changes and how pathology disrupts these trajectories is what's going to be most helpful in identifying abnormalities in the cases that we see. So this is just a couple of acknowledgements to my team and my colleagues here. And with that, I truly thank you very much for your attention. Thank you to Adam for thinking of me. Thank you to Neil for letting me go second. You are the kickstart that will continue to bring more people forward. Thank you to Susan and others for attending. And please do not miss the next one, which is by my good friend Shri from Pittsburgh Children's, which will be on pediatric head and neck masses. And with that, we'll take questions.
Wow, what an incredible lecture. Thank you so much. We have definitely a bunch of questions. I don't know if you want to. So Susan says, thank you so much. Do you do T1 IR of the fetal brain?
So we don't do it here, but I've seen images and I think they come out quite nice. The reason we don't do it here is that the T1 vibes that we do are easy to do, and they're fairly robust. And we do ask mom for those to hold her breath, and it actually takes about 6 seconds. So we almost invariably get a good quality of them. They're fast, and the questions that we have for the T1 vibe more often than not are very binary. It's like, do we see a hemorrhage? Do the folks in body see the meconium? So I would say maybe we have been satisfied and not pushed as hard as we should. So I don't think we do them, but I think we should and explore and push the T1 contrast more.
That's great. Amazing lecture, excellent talk, incredible. How do you do fMRI in fetuses? Is a question.
With a lot of love. No, so what we do is, the sequence runs, right? Like the sequence is very quick, you'll acquire the volumes. The problem is the fetus is jumping all over the place. There are two, I would say there are two things that are really important to get that to succeed. First is you have to image for longer, So depending on when you're doing resting state, I don't want to be dogmatic, but people say, acquire at least 6 minutes. It's nice to do 10. So you have to realize that you're going to have more data that's degraded. So image probably for 15, assuming you're going to lose a lot of data. The second thing is have a way to recapture that data and to do really robust motion correction. So the motion correction that you do for imaging a child is not gonna suffice for this. So, but the data is there because each one of these EPI volumes is so quick. So we created we have a neural network that's basically doing that. It's kind of reorienting the data in space. Those two elements I think are the quintessential ones, which is so assume you're going to lose more data, so image for longer, and to have a mechanism to do motion correction, which you always would do, but have a robust, and we have developed one in-house. The folks at NYU are doing a fair bit of functional fetal MRI. And obviously it goes without saying that at least everything I've seen thus far is resting state of the fetus, right? So we're not pulling any task or asking any hard questions to the fetus. So that's what we've done thus far.
Okay, next question. What do you use as a brain atlas, map or template?
Great question. So the best one and what I like the most, I was going to type, but I think I'm going to get into trouble, and it's easy enough. So fetalmri.org is a really good resource. It's a collaboration. It involved one of our radiologists, Ellen Grant, and some folks from the other side of the pond to put things together. I think that is a very, very good resource. I would say there's anecdotally something that's important to mention, and is that as technique changes, the atlases are more or less helpful in the sense that if your imaging becomes better and better, things will look a little different. So the first hint I had at this is there are a couple of printed atlases in the reading room that are from like the year 2000, where the slices were 5 millimeters thick. And there's nothing wrong with that. But if you compare a 5 millimeter thick slice to a 2 millimeter thick slice, the 5 millimeter thick slice looks like a MIP. So some of our fetuses looked a little undersulcated for that reason. It's not undersulcated, it's that in each one of those slices, you're being able to fit 2.5 of the ones we're doing or something like that. So realize that atlas are not timeless, and you probably should look for a resource that's closer to the way you practice. The one that's closest to the way I practice, and it's one that I think is very, very well done, is the one I mentioned, fetalmri.org, because you can also scroll through very easily through gestational ages, and they're reconstructed in 3D. So anyway, that's the one I would recommend.
Oh, that's great. Yeah, I've used it too. It's a great resource. And I guess on a similar note, what kind of measurements do you usually provide in your reports?
Over here, we don't provide too many. I mean, we always measure the ventricles. We always measure an abnormality that we see, a bleed, blah, blah, blah. We don't provide that much biometry because they all come for a same-day fetal ultrasound, where they're obtaining the standard biometry. So I think if you're doing biometry that same day by ultrasound, I think you can only get in trouble if you say the corpus callosum measures 12 for the neuroradiology, 13 or 15 for the body radiology. So I think that's better done once and done right. So we do. We have some things that are divided, and we've kind of assigned responsibilities. I would say the biometry, we always we rely heavily on the ultrasound, and only one person reports it, and it's reported by the sonographer for the most part. If the ultrasound is non-diagnostic, then one or the other will report the biometry of things like the corpus callosum, the ventricles everyone reports, and the height of the vermis. But we don't typically measure biparietal or frontal diameters in the AP dimension, because really the head circumference, it has such strong validation, and there's so much data around it, and it's I think more reproducible than the fetus, which is doing this every time. So I think that the ultrasound biometry really does a good job. That's our practice.
Okay, great. Do you have any experience with fetal spectroscopy?
So I would say secondhand. I've only seen it done for research purposes. It was done heavily here at Children's before Catherine Lamperopoulos moved to DC Children's 10 years ago or so. And it was also done at the time, and I'm not saying it wouldn't work at 3T, I'm saying at the time, it was done heavily on a scanner, on a 1.5 Philips scanner that, that I've seen the data, kind of legacy data that's left in the packs, and it worked very well. I think we have not done it clinically. I have done it in one case, but I did it in the pyruvate dehydrogenase case because we actually knew what it was. And yeah, that was lactate, but I'm like, I knew it was a pyruvate dehydrogenase. And then I'm not sure that, in a fetus that small, that the voxel is not catching a lot of CSF. So I'd say it's technically challenging. When we've tried it for research purposes, we found it very challenging. So I would say I am not the person to help you with MR spectroscopy, whoever asked this question. But what I would say is, if you find someone that can do it well, just give them my number. I'd love to talk to them so that they can help me with fetal MR spectroscopy.
Awesome. It's 4 o'clock. Do you have time for one more question, or we could?
Let's do it.
Okay. So, do you comment on the placental state regularly? Any trips to remember, tips or tricks?
I would elegantly decline to self-incriminate. I'll plead a fifth. That's one of the things that our body radiologists have, that we have sort of divvied up, and our fetal body radiologists sort of own. And so we are not a referral center for abnormal placentation. So those cases don't come to us heavily. When we find them, and obviously they do occur, I would say we have also, as I said, turfed that to the body folks, and we adhere to that strictly. But it's not with the idea of being lazy. It's more to the idea of like the worst thing we can do is give contradictory information to physicians, to referring physicians. So we look at it, but we don't comment on things even as basic as the placental location and things like that. We've split up, and that's how we do. So I am not your placenta guy. Sorry.
Okay, awesome. Yeah. So I won't take up any more time. Thank you so much again. And also to give a shout out, there's the SPR fetal imaging course, which is tomorrow and Saturday. Also, if anybody's interested in more fetal MRI lectures. But thank you. And if anybody's interested in getting emails for the next one, feel free to email me. I can send out the invitation directly. If not, it'll be on Twitter. And yeah, see you all next time. Thank you again so much. And yeah, have a great weekend, everybody.
Thank you.